I want to start off by saying thank you to everyone who has contributed to this. It has really and truly been a team effort, even though we are implementing the AIM bundle for severe maternal hypertension. It still takes a lot of work to translate that from their documents and framework into something that works effectively for the state of Florida. So the name I want to point out stands for Pregnancy-Related Optimal Management of Hypertension. It is our first initiative ever named by AI. Dr. Fryer was doing ChatGPT when we were generating names and came up with this one, and we thought it was very relevant because it's all about getting prompt identification and treatment for women with severe hypertensive disorders. Let's go to the next slide, please. So if you're in the call today, we hope that you will keep yourself muted unless we reach a point where we're having Q&A, in which case, please either write it in the chat or raise your hand before you jump in. And just a reminder to all, in case you've joined since we started recording, this is a recorded webinar, and it will be available to others to see afterward, because we know many people are out there taking care of patients and weren't able to join us. So it will be available for people to watch later. Next slide, please. The Florida Perinatal Quality Collaborative's vision and values has changed a little bit over the years, but it has always been centered on making sure that Florida's mothers, infants, and families have the best possible health outcomes by receiving respectful, high quality, and evidence-based perinatal care. And we hope that this care would always be data-driven, that it's population-based, that it's evidence-based, that it is respect-centered, and that it is value-added for the hospitals that participate and for the families that benefit. Next slide, please. We know that since 2022, when the Florida legislature slipped language into a new statute that required all Florida maternity hospitals to do 2 initiatives each year, that created a lot of work on the hospital side, but you all have stepped up and everyone is doing at least 2 initiatives. We have a handful of hospitals that actually are doing 4 things at once, that are doing both our maternal initiatives and doing our NICU initiative and also doing PQI. So thank you all for your dedication and effort. I think everyone benefits from it, but we do recognize that it's a lot of time and effort on your part, and we appreciate it. There are also CMS and Joint Commission requirements for participating in perinatal quality collaboratives. I'm not going to go into details on those, but all the more reason that we value your participation with us, and we hope that it helps you achieve your goals as well. Next slide, please. We have to always recognize our partners and funders. There are many on this slide. And in addition to this, as I already mentioned, there are many volunteers that just give their time to be part of a maternal health committee, an infant health committee, one of our work groups or advisory committees, and we are grateful for all of them and could not do this work without their support. Next slide, please. Okay, just a little bit about who's working on this initiative in leadership roles. On the clinical side, we have Dr. Cole Greaves, who is a maternal fetal medicine specialist, but also is the Associate Director for Maternal Health for the Florida Perinatal Quality Collaborative. We have Margie Boyer, who is our nurse clinical lead for our maternal initiatives. We have Dr. Daniela Cruziat, who is, for the first time ever, she's our first cardiologist to work as a lead on one of our initiatives. We've had them at the table before, but Dr. Cruziat has taken a lead role and is a very rare bird of being an obstetric cardiologist who works very closely with Dr. Ashley Kane, who is also a maternal fetal medicine specialist. They've done a phenomenal job providing the clinical leadership on this initiative. We also have a family lead, that is Mandy Gross. You'll hear from her later today as well. On our staff side, myself, Dr. Linda Detman, who does our Associate Director for Programs and Operations, Nicole Pellegrino, who is our Senior QI Program Lead, Dr. Estefania Rubio, who is our Associate Director for Data and Information Science, and then we have analysts. We have a Stephanie Martinez. I almost gave a Stephanie a promotion to doctor. We have Sarah Steuben, who is another analyst, and will be the lead analyst for the prompt initiative. And then we have Shelby Davenport, who is a data analyst, who works closely with Dr. Rubio, and you'll see her on the calls, providing data support to help you understand how to enter and understand the data that you report over the course of the initiative. Next slide, please. So what we're going to do today is just a little overview. Why are we doing this initiative? What are the benefits of working within a collaborative structure to do quality improvement? We're going to do a little bit of a data overview on hypertensive disorders of pregnancy, particularly looking at what it looks like in the state of Florida. We'll do a little overview of the prompt initiative so that you understand what components we're going to be focusing on. We'll go through the frequently asked questions, and then we'll talk you through how to apply to be part of the initiative if you choose to do so. Next slide, please. And this is just a current snapshot of what we are working on. So you can see for maternal health, we just wrapped up the PAC initiative. Many of you on the call probably were participating in PAC. It was an enormous success. What a great effort. Hospitals just blew it out of the park in that one. We are still doing mother-focused care. That finishes later this year. And then prompt, the kickoff is on October the 23rd. The implementation phase begins January 1 and will go for 18 months. Next spring, so here's in case you have to make a decision about whether you want to do this initiative, depending on what your bandwidth is, we will also be doing an obstetric hemorrhage initiative that will kick off in April of 2025. We have 2 infant initiatives as well. We just finished an infant initiative, and we're now working on Homeward Bound. We'll start another infant initiative in 2025. And then, of course, on an ongoing basis, we do perinatal quality indicators, and I think everyone is enrolled in that. And PQI actually does count as one of the 2 mandated required FPQC activities. So if you can only do one quality bundle at a time, PQI helps you meet the statutory requirement without being completely overwhelmed. We also do birth certificate training because we use a lot of birth certificate data, and we've learned over the years that we get better data if the people who are responsible for entering the data get training along the way. And then last but not least, we do levels of maternal care. We now have 31 hospitals in the state of Florida that are verified for their level of maternal care, and I want to congratulate all of them. We continue to have resources available for that going into 2025. So if you're still interested in your hospital participating in the verification program, let us know. We can get you set up, help you with the application process, and get you on board. Next slide. So this is just a kind of a look at how we decide on which initiative we are going to do. The first thing we do is we form the maternal health committee, and actually shouldn't say form because we always have a maternal health committee, but we convene that maternal health committee, and we then look at the data. What does the Florida data tell us? What are other perinatal quality collaboratives doing around the country in this area? What guidelines are there at the national level that could inform the work, and who are the stakeholders on the ground that would need to be engaged? We also poll our hospitals to ask them, what initiatives are you interested in doing? Where are your areas of need? Because we don't want to implement an initiative that doesn't meet your needs. We want to make sure that we are working in tandem with you and headed the direction that helps you achieve your goals. Once we have all of that information, the maternal health committee votes. And as I already mentioned, the prompt initiative on hypertension, this will be our second time around to do a hypertension initiative. We'll talk a little bit more about that later on. And then the next one, of course, is obstetric hemorrhage. Somebody tell me when I'm at slide 10. Next slide, please.
This is it.
This is 10. Okay, so this is my last slide, and then I'm going to hand off to Margie Boyer, and she's going to step in for another section of the presentation. So the prompt initiative timeline, we already talked about hospital recruitment. It is open now. We already have quite a few hospitals that have submitted applications. If you're interested in applying, you can submit your application anytime before September. I don't have a specific date in September yet, but we may talk about that later. The kickoff meeting is October 23rd. If you do sign up, we expect you to come with at least 2 members of your QI team from your hospital. That is a mandatory part of participation in an initiative and very important ultimately for your success. We also will do baseline data collection and work on helping you recruit your leadership team. And then beginning in January of 2025, each hospital will kick off their initiative. By September next year, we'll do a mid-initiative meeting. And in between then and now, beginning in January or February, we'll do coaching calls. And if you've done any other initiatives, you're already familiar with coaching calls, so I don't need to go into depth there. The initiative is scheduled to finish in June of 2026. Usually May would be the last month that data is entered. And then we would ask you to do a post-implementation survey. So that's it for my section. I'm going to hand off to Margie Boyer, and she's going to talk about the next few slides.
Thank you, Lori. So the first thing to go over is why would you want to participate in an FPQC initiative? And I know many of you know the answers, but first of all, we do provide a complete QI change package at no charge. I know many hospitals, in my experience, we paid big bucks to have someone come in and do this for us. So this is all at no charge. We have the change packet. We have the data reporting, coaching, mentoring, sharing ongoing. We do everything is evidence-based. We have the guidelines there for you, research, best practices, and we also have national expert consultation. We do know that multi-hospital QI initiatives, there's evidence that shows you're going to get more sustainable QI practice gains by working together with a collaborative. We have a lot of great networking among clinicians, especially on our coaching calls, incredible work sharing going on there. We also provide publications, presentations, education, and we do offer leadership opportunities as you become more involved with FPQC. We do promote state and community system improvement, so we're working across the entire state to have all the key partners around the table. And last, as Lori said, this does meet the Florida statute requirements. Next slide, please. All right, here are all of our resources. I know many of you on this call are already a part of our monthly coaching calls. Our participation rate is over 95% of hospitals actually participating every month on these calls, so it's pretty incredible. We do provide a toolbox, which is going to have all the algorithms you need, sample protocols. We continue to add to the box as the initiative moves forward, as people share their best practices. You can also find slide sets in there that you're welcome to use. We do offer educational sessions, videos, resources, snippets for you to use at your meetings at your hospital. We also have initiative-wide collaboration meetings, and the data is so rich from FPQC. You will be getting monthly and quarterly QI data reports that you can share with your team. We also produce regular email bulletins to the latest and greatest, and we love to feature our hospitals with those e-bulletins. We do offer customized, personalized virtual phone consults or in-person consults. We do have coach mentors that we've trained and are happy to do grand rounds, virtual or an in-person site visit. And then technical assistance. The FPQC team is incredible. We have national experts on our team and that are happy to work with you if you need any help with data and beyond. Next slide. For this initiative, what we are going to do is build a strong collaborative. Really want to support hospitals in driving this change around prompt. We are going to coordinate state and national experts, have these resources available to you to support your change process. We will continue to offer oversight and change management, process management for this initiative. We will be providing, as I said, evidence-based information from clinical experts as well as quality improvement experts. And then again, the tools and resources you will be needing to implement this change. And last but not least, we're going to develop, adapt, and update these materials in our toolbox ongoing as the initiative progresses. We love to hear about best practices to share with others. Yes. The participating hospitals are going to, what we expect from you all, we want you to develop a very strong QI team. And the most important thing, one of the most important things here is to have people really at the front end, the sharp end, nurses, physicians. We also need those administrative champions as well that can help support this change to participate, have regular team meetings, and then participate in our coaching calls. Complete a pre and post implementation survey. We will help you with that. Attending the kickoff and mid-initiative to participants at each of those. Also, we would love for you to look at your department policies and make any changes that you feel are necessary in order to be in line with what FPQC is recommending. Coaching calls we talked about in webinars. We want you to participate at least one hospital rep on each coaching call, ideally at nurse, doctor that actually is at that hospital campus, not, and system-wide people are welcome as well, obviously, and the data team. Scheduling educational assistance, please reach out. We will ask you, if you need help, please reach out to FPQC. We will help you get something set up. Also implementing change. We talk a lot about small tests of change on all our coaching calls. And then we are going to expect that you would submit your hospital assessment, your data timely and on a regular basis, and the data team will help you with that. And I believe that is my last slide, and I'll hand things over to Dr. Cole Greaves to take it from here. Thank you.
Good afternoon, everyone. Can you hear me okay? Great, perfect. So I'm coming to you right from downtown Orlando, where we're actually hosting the third quarter maternal mortality review committee meeting today. So I was able to take a quick break here with Stephanie Rubio to present some of the maternal mortality data that kind of drives some of the work that we do in the Florida Perinatal Quality Collaborative. So with respect to hypertensive disorders of pregnancy, hypertensive disorders of pregnancy are the leading cause of pregnancy-related death in Florida for the 2020 year, which is the most recent comprehensive year of data that we have coming out of the work of the Maternal Mortality Review Committee. And how the committee works, every quarter, we review cases of maternal mortality. Typically, on a quarterly basis, there's anywhere from 45 to 60 maternal deaths that occur. For a total of about 200 to 225 deaths per year. And then the first evaluation of those is to look at them and separate out those that we don't believe are maternal, pregnancy related. And then we evaluate only the ones that are pregnancy related. And each quarter we're looking at anywhere from 12 to 16 cases. And then we really drill down on those which are pregnancy related and potentially look for ways that we can mitigate risk. So in 2020, the MMRC found that hypertensive disorders accounted for about 18.2% of all pregnancy-related deaths. And in that year, it emerged as the leading cause. About 66% of those deaths occurred in the postpartum period prior to discharge from the hospital. And if preeclampsia and eclampsia had been diagnosed and treated early on, those deaths were all potentially preventable. This is what the years from 2018 to 2020 looked like with respect to Florida-related pregnancy-related deaths in the state of Florida. Again, hypertensive disorders accounting for just over 2.5 per 100,000 live births, followed by thrombotic embolism, hemorrhage, cardiomyopathy, and cardiovascular disorders. And these juggle back and forth, kind of competing for the leading cause year over year. But 2018 to 2020, it was hypertensive disorders, and that's why we felt it was important to really drill down on that. This is how we compare, looking at the state of Florida versus throughout the entire country. Data compiled from the CDC and Maria paperwork that's completed by each state's maternal mortality review committee. As you can see, hemorrhage, infection, and hypertensive disorders are the leading cause in the state of Florida, and shown here is Florida in the green bar and the rest of the United States in the orange bar. And what's notable about hypertensive disorders is that we clearly have some work to do here as a percentage of overall maternal mortality. We are more than double that of the rest of the United States in the area of hypertensive disorders. So hypertension in pregnancy is common and it appears to be rising. In 2022, 19.4% of delivery admissions had a hypertensive disorder of pregnancy, and this is an increase from 13.1% back 5 years ago in 2017. Importantly, it disproportionately affects the non-Hispanic Black population, and it's also, in addition to a leading cause of maternal mortality, it's a significantly leading cause of severe maternal morbidity. It's a critical risk factor for both short and long-term severe maternal, fetal, and infant complications. This next slide just shows more graphically the disparity and difference between the non-Hispanic Black population and non-Hispanic white population and Hispanic population. Approximately 2 times that of the others for the non-Hispanic Black population, 8.2%. And again, showing an increase across all demographics between 2017 and 2022. This graph really separates the hospitals out by quartile, with the black line, and I'm talking about the upper left-hand graph here, the black line representing the averages for all Florida hospitals for percent of severe maternal morbidity among severe hypertensives. And as you can see, the green section is sort of the lowest 25% of hospitals, representing kind of that first quartile. The second, the purple shaded area would be the second quartile, the lavender shaded area, the third quartile, and then significantly the red quartile representing the fourth quartile. And though we have made some improvement from 40%, we still have a ways to go, in particular with the third and fourth quartile. And then the lower right-hand graph is showing percent of severe maternal morbidity among severe hypertensives and preeclamptics, separated by demographic, by race, with, again, the non-Hispanic Black population representing the highest percentage. And these are, each hospital kind of has their own breakdown of that. So why the importance of timely treatment for persistent acute onset of severe hypertension? It's a well-understood best practice that's been endorsed by the American College of Obstetricians and Gynecologists. Consistent implementation of treatment protocols still remains challenging, though, getting that messaging out to the hospitals and making sure that people are promptly treated within that first hour of identification whenever there's a severe hypertensive episode encountered. As it turns out, less than half of persistent acute onset severe hypertensive episodes receive treatment within the recommended 60 minutes. And the Hypertension and Pregnancy Initiative back in 2015, sort of the first initiative that the FPQC did on this topic, showed that participating hospitals treated only 20% of persistent acute onset severe hypertension at baseline within that first hour. 61% of preeclampsia-related deaths in the state of California were due to stroke, and 96% of these stroke cases were preceded by a systolic blood pressure that fell outside of the range 160/110. So there's a good to reasonably strong chance that outcomes could be altered in the 66% of stroke cases. The main issues seem to be a slow response to warning signs in 91% of patients and an ineffective treatment in 76% of cases. This is a slide kind of showing where the FPQC's Hypertension and Pregnancy Initiative in 2015 through 2017 took us. As you can see at the beginning, most importantly here, the blue shaded area, no women treated within 1 hour. At baseline, 43% of the participating hospitals had no women treated within 1 hour when there was a severe hypertensive episode identified. As you'll see, as we ran through the initiative over that period of time, those hospitals disappeared. Everyone had at least some patients that were treated within that hour. And if we flip forward all the way to the right, April of 2017, upon conclusion of the initiative, 63% had 75 to 100% of women treated within 1 hour. So 63% of the hospitals were treating 75 to 100% of their patients within that 1 hour. And the remaining 38% treated the rest of the patients, 1 to 74% of women within that 1 hour. And again, importantly, no hospitals had no women that were treated outside of the 1 hour guideline. This is one of our favorite slides, because as we talk about why reboot an initiative, why do something a second time, this is really showing why we would do that. If you have not participating hospitals in any initiatives, you can expect to see only a 1.2% reduction in severe maternal morbidity rates. And this is among hemorrhage patients, but I think the same is true with hypertension and all the other initiatives that we do. If there's prior experience participating in a perinatal quality collaborative initiative, you can see a percent reduction of up to 15.4%. But if you have prior experience and then you do it a second time, you can actually double that reduction to 28.6%. This is what the data has shown in California through the CMQCC hospitals participating in hemorrhage initiatives. So again, this is the idea that a lot of times people will say, well, gosh, didn't we do that once before? Well, we did, but things have changed a little bit in the management of hypertensive disorders, and particularly severe hypertension. And we hope to have even more hospitals participate, and some of those hospitals who participated previously participate again to get this close to double a reduction than what was previously seen the first time around. I think I'm going to hand it off now to the next speaker.
Thank you, Dr. Greaves. I'm Daniela Cruciat, one of the clinical leads for this FPQC initiative. And over the next slides, I'm just hoping to cover a little bit about what our initiative is exactly all about. So we are very lucky to have the guidance of the AIM severe hypertension package that was revised, I think now in 2022. So now we're stepping back away from it. But as you guys are aware, AIM is the Alliance for Innovation in Maternal Health, and it's really sort of our national effort to improve through best practices the care that we provide to our mothers and babies. So we are incredibly lucky to have the guidance of the AIM bundle, which will really sort of form the primary infrastructure of what our initiative prompt will have in terms of its key components. So I wanted to sort of highlight what those key components will be. And then we'll talk a little bit about the nuts and bolts within each of them so that you can get excited about what our initiative will provide for you guys. So at the cornerstone of our severe hypertensive initiative will really be to make sure that we are ready. And you'll see that every is in every single one of these boxes. So what this means is that our aim is truly to do this every single time. It's really about consistency in all areas. So we want to make sure that hospitals are ready, that they know exactly how to act, that they have those protocols, that people know how to recognize severe hypertension, and this is both patients and providers, and that we have a response system in place. And with every initiative we run through FPQC, we want to make sure that we're giving you the support to accurately process the data, to look at outcomes, and also to ensure that we're always providing respectful, equitable, and very supportive care. You can go ahead and go to the next slide. So this is our prompt AIM. I want to make sure we kind of read it out. And I think with a lot of the things that Dr. Greaves mentioned, this was truly what led us to decide, out of all the things we wish we could do with improving the care of our women and their babies with hypertensive disorders of pregnancy, where should we really focus in on? So our prompt aim is twofold. By June 2026, we're hoping that all prompt hospitals that engage in this FPQC initiative will increase by 20% the percent of patients of receiving two things. The first one is really to timely treatment of persistent acute onset severe hypertension within 1 hour from that first severe range BP reading. And as Dr. Greaves mentioned, really only about 20% of hospitals were doing this before even our other hypertension and pregnancy initiative that took place, I believe, in 2015. But by the end of that initiative, really more than sort of 2/3 or 60% of our hospitals were treating most women presenting with severe hypertension really within that 60-minute or 1 hour mark. So the increase by 20% is exactly because we don't know exactly where every hospital is starting. We want everyone to sort of improve the percentage of women that are currently being treated for that. The Holy Grail is 100%, but we want to see an improvement, and that's the reason why we picked that as the first metric. And then the second metric really comes from thinking that even though this is a hospital-based initiative, we know that it's not over after women are either seen in the ED or triage or potentially sent home. So one of the biggest factors we want to make sure that we embrace is sort of what happens, what kind of education needs to occur at the time for both the patient and their family or their support people. Do they have the right education to know when they need to come back? And are we then setting them up for success in terms of scheduling them for appropriate follow-up within 3 to 7 days post-discharge? Next slide. So our aim is right here on the left. I won't repeat those. These are sort of the primary key drivers that will help us to achieve that aim. And as we talked about, I know we had showed sort of 5 different buckets in the AIM severe hypertension pregnancy bundle. What we've done is sort of put the reporting and systems piece and also the respectful, equitable care into each of our primary key drivers, which are readiness, recognition, and response. So the 3 R's, which I think are easy to remember. So these will all entail things like implementation of standard protocols in our hospitals, and that's independent of which hospital we are in, and being conscious of the resources that we have. early recognition and identification. And this is really for all providers who could be engaging with pregnant or postpartum women. And this is really in every unit, whether it's in the ED, L&D, or a non-birthing unit. And then our response system in terms of once we've identified severe hypertension, what are the protocols that we have in place to make sure we're appropriately treating and responding. Next slide. So the next two slides are just a little bit of flavor of the things that we think will be an important part of our aim and really our primary and secondary drivers. So I think a lot has changed. There's some, since we last did our hypertension initiative. Why is it important? We just saw all the data to support that unfortunately this remains a leading cause of death and also morbidity for moms in Florida. And there's been a lot that has changed in the hypertension and how we treat it over the last couple of years. So we want to make sure that all the standard protocols and the guidelines that we have currently in place are sort of up to speed with the latest guidelines in order to sort of make a hypertensive disorder pregnancy not the leading cause of maternal mortality, particularly in Florida. We do know that there's such an important piece to have either birthing individuals or postpartum individuals to be a part of the advising team. And this is something that we've tried to put into every single one of our sort of work groups and aims. And I mentioned this piece a little bit, but not just providing the comprehensive and timely care when the patients are in the hospital, but thinking a little bit about how do we arm our patients for success after they've had either an admission or a visit to our hospital complicated by hypertension. And this really runs the gamut from like, do they know how to check their blood pressure? Do they know what the signs of postpartum preeclampsia could be? Do they have a blood pressure cuff? Is it a time to maybe even speak to their support people or their family members who may be at home with them and help us recognize some of that, and making sure that we're also doing debriefs and trauma-informed care. This is one of the things that has come up time and time again from our patients who have unfortunately had complications in pregnancy from hypertension, but it's just, it can be really difficult, I think really challenging. And I think it's our due diligence to kind of recognize that and make sure that we are addressing all parts of providing support for our patients. Next slide. We think that we have a ways to go in terms of educating all of our providers. And again, in every unit and every event and every patient in terms of what severe hypertension is and preeclampsia and what the complications could be. So this initiative will involve processes and different procedures of exactly recommendations on how to do that. One of the things we're really excited about in this initiative is the fact that we've been working on both interprofessional and interdevelopmental drills, sort of like simulations. We realize that pregnant women with hypertension could be sometimes anywhere in the hospital, and this is something that we need everyone to recognize. We also know that there's a lot of players that go into like the quote unquote timely treatment, which is really our aim. So that can involve people in quality, that can involve things like pharmacy, it can involve the emergency department. So I think one of the things that is very germane to this aim is to make sure that we're keeping all those really important players in mind, because I think they're all going to be key for us to really reach our aim. And last but not least, I'd have to say the implementation of a universal asking people if they've been pregnant. If we don't know, then we can't recognize. So one of the big things with this is just knowledge and empowering people to know what the complications are, knowing that there can be complications even after delivery. So I hope that this initiative will not just be in pregnant women, but also in the postpartum women, knowing what those morbidity and mortality rates look like, particularly after women deliver. Next slide. Oh, perfect. So I think now I'm going to pass it off to the next speaker, Stefania.
Thank you, Dr. Cruciat. Good afternoon, everyone. Thank you for joining us today. So we're going to talk a little bit about data. Data is an essential component of quality improvement. Data help us identify specific issues, set benchmarks, and measure our progress over time. As a collaborative, your data really help us allocate resources, including engaging the stakeholders as needed, and also helps us continuously refine our strategies to better support you. Plus, we also know that what gets measured gets managed, right? So data is very important to track. I have to note that our commitment to you is that we keep your data confidential at all times, and we only use it for learning and support. It's never for punishment or for pointing fingers at all at any time. So we try to keep everything very transparent, so you all know where your data is going and how it's being used. We've also been very mindful to only track the data needed to support the initiative in a way to reduce the burden on your hospital teams. So all the data elements that you will be collecting as part of the initiative has been vetted and really are going to help us inform the initiative. With that being said, we have 3 types of data that we're going to be collecting in this initiative. If you've worked with us, this is going to be very familiar. But basically, we have monthly abstracted patient level data. So we're going to ask that you go into 10 patient charts that have had acute onset severe hypertension, or as many as you have, because in some units you may not have 10 patients monthly. And that you abstract certain process measures and certain demographics that are going to help us see if the activities or tasks that you're doing at your facility are giving the results that we're hoping. We're also going to ask that you abstract up to 5 severe maternal morbidity cases. And that is going to be among patients that have had severe hypertension, and that's going to be defined by CDC. We're going to provide all the tools, all the definitions, everything that you need to accurately identify those patients, and then the tools to abstract the data effectively as well. As mentioned, you're going to be looking at demographic information and process measures on identification management and patient education. The second level is the quarterly aggregate patient level data. This is not our aim, but we're going to keep tracking it because the purpose of reducing, of better handling severe hypertension is to reduce severe maternal morbidity as possible, right? So we are going to be looking at those quarterly rates to see how it's having an impact on this population. And the third type, if we go to the next slide, you're going to see that we're going to be looking at quarterly hospital level data on staff education, policies and guidelines to support PROMPT, which is basically just a quarterly update of what your hospital has implemented from the PROMPT packet. So we're going to, again, provide all the tools, all the resources that you need, but you are the ones doing the work, the hard work at the hospitals, implementing all these policies, these guidelines, this education for your patients and providers. And so we're just going to be looking at a quarterly update of the implementation of these specific measures. So with that being said, we're going to open the floor for questions. And we're going to be monitoring the chat. You can raise your hand, come out of mute. Anything that works for you works for us. Just let us know your questions, your thoughts so far.
Hi, I'm Mandy. I'm going to walk you guys through some of our frequently asked questions to get that started. First, I just want to say thank you all for being here and working towards maternal health. As a postpartum preeclampsia survivor, PROMPT is very close to my heart, and I sincerely appreciate all of your care towards the topic. So our first question in our frequently asked questions are, how many champions does our hospital need to participate in this initiative? We are requiring a minimum of 3 from each hospital. We encourage additional members, but we know that some smaller hospitals might not have more people. So you must include an initiative lead, a provider physician champion, a nurse champion, a data lead, and a hospital administrator. You may have one person wearing more than one hat because we understand that there are, again, smaller institutions, but no single person may take on more than 2 roles. So a minimum of 3. We, of course, encourage more. It must include the bolded ones, but you cannot do more than 2 roles. We also recommend, but do not require, someone from the emergency department, from pharmacy, a nurse educator, someone from cardiology, anesthesiology. We're really trying to do interdisciplinary approaches here. So the more different departments that work together, the more we could get achieved. We also strongly recommend a patient and community representative, which is my role on the FPQC. And during the PROMPT initiative, our toolbox will have many ways and strategies to find and train these individuals. Next slide, please. Thank you. Who should be the initiative lead? Well, the initiative lead is the person making commitments for the hospital. They will be the hospital's team leader for the initiative and the main contact that FPQC will contact with information, questions, etc. So they should have influence to drive change and have oversight and management. And we understand that everyone is super busy, and we're always respectful of all of your time. Next slide, please. Are there opportunities for hospitals to have personalized one-on-one programmatic support during the initiative? Yes, we're here for you. We do in-person, virtual, or phone assistance. We're available to all the participants, and we'll even do on-site consultation if you request it. FPQC is tailoring assistance to meet your needs, and it could include anything from grand rounds to virtual participation in team meetings, peer-to-peer consultation, office hours, or anything else that you would find helpful. Reach out, we're here for you. Now I'm going to pass it to Dr. Linda Detman with the next FAQ slides.
Thanks, Mandy. So going on with our FAQs, who from the participating hospital is required to attend the initiative in-person meetings? While we would really love to have your entire teams be able to participate in these meetings, we do have limited space. And especially for this initiative where we are expecting to have many of the hospitals in the state participate, 2 people from the team are required to attend. And this is so that you can get the training and the information and take it back to your team. If we have space, we can allow additional team members to participate, and we will have a set aside, we'll keep a list of those who may be interested and contact them individually if we have space for them. Next slide, please. Is there a cost to participate in these initiatives? So while we ask that you pay a small fee to attend the in-person meetings to cover some of our expenses, there is no cost to a hospital to participate other than your sweat equity, your time and your effort. This initiative, the PROMPT initiative, is supported by the Florida Department of Health and the CDC, and we get additional in-kind support from other professional organizations across the state. Is our hospital responsible for IRB review and approval? So we get asked this a lot. FPQC will submit a protocol to the University of South Florida Institutional Review Board just to assure that that all of the procedures meet any sort of requirements. Each hospital, however, may have to do their own IRB. So each hospital will have to determine whether or not that is required for you to participate with us. You should understand that at least from a federal perspective and federal guidance, most quality improvement initiatives are considered to be not human subjects research because we're not doing research, we're doing quality improvement. But that's something that you'll need to take up with your own hospital. We will provide to any hospital that requests it the protocol and the approval letter that we received from our IRB if that assists you in your own. How will initiative data be submitted and protected? So we will provide to all of you a HIPAA-compliant online data portal using REDCap to submit your initiative data, and somebody from your hospital will be the designated person to submit data on your behalf. We will also supply you with the data use agreement that will detail how we are protecting, using, and keeping confidential the data that you submit, and that will be part of the application process after you have done some of the other approvals that we need to receive from the initiative team members, and the commitment letter will send a data use agreement for you to go out to the hospital legal department to be signed. Keep in mind that FPQC is not a vendor and we don't provide services to your hospital, so we don't need to have a business associate agreement with your hospital in order for you to participate. Can we apply to be in more than one quality improvement initiative? Absolutely. All of you in a hospital here in the state are currently participating in our perinatal quality indicators initiative. So you're already in one. The Florida state statute requires that you participate in 2 maternal and/or infant health initiatives at all times. So participating in this upcoming prompt initiative would be a second. Many of you, though, we know, participate in more than one, and we welcome your participation in any of FPQC's activities. If you need additional information about what's going on with us, of course, you all know where to find us at fpqc.org. So how do I get my hospital signed up for prompt? So we would like you to complete the application to participate, and it's available through a Qualtrics survey. We'll give you some information on how to access that in a moment. After you apply, we will reach out to you and request that every member of your team respond to an email indicating that they individually commit to participating in the initiative. We will also ask you to have a hospital commitment letter signed. We'll send that also via email. And then after that, we'll send the data use agreement and ask you to route that through your hospital's appropriate process for signature. And then you attend the in-person kickoff meeting, which is on October 23rd. How can we get announcements about recruitment or other information? You, of course, are getting that now, but you can join our mailing list if you have not already. You can go to fpqc.org and at the Get Involved navigation bar on the left, give that a click and you'll be able to sign up. We also have a Facebook page that you can join, the FPQC Maternal Health Discussion Forum. So you can see here, the application deadline is September 20th. We've provided here a QR code for you, which you can whip your phone out right now and grab that and you'll be able to apply. The application URL is also included here, and someone I think has dropped it in the chat as well. Always feel free to contact us at FPQC if you have questions. Our email address, fpqc@usf.edu. Many of you know our individual emails. Please feel free to reach out to any FPQC staff member if you have questions. We want to help you as you decide and put together your application to participate in this initiative. We mentioned this many times. Keep in mind and mark your calendar now, save that date, October 23rd, for the kickoff of the prompt initiative. Remember that we must have 2 individuals from your hospital participate. We cannot have more than 2 until we know that we have space. So if you plan to participate, please mark this date on your calendar now. So we've gone through all of our frequently asked questions, but we know you all have questions. I've seen a few pop up down below as I've been chatting. So we will start to address those questions as we can. You can also feel free to unmute yourself, raise your hand first, please. We don't want people talking at once. And here are the many ways to reach us: Facebook, X, I think that's Instagram. You can join our mailing list. You can send us an email. We do want to hear from you. So thank you. And let's, I think someone can read whatever questions we have. Maybe Lori, you have those?
Well, I was going to see if Sarah could dive into the chat box and let us know what questions are there. And meanwhile, we'll watch. If anybody has a question you want to raise your hand, we'll call on you.
Thanks, Lori. A question that I see in the chat from Lachelle is, have we looked at PO treatment guidelines once they are identified as hypertensive for these patients that are inpatient? Many providers are reluctant to start them on medication and then have them come back as a readmission.
Well, I think we have the perfect people to answer that question. Would Dr. Greaves or Dr. Cruziat like to take a stab at that one?
I'm happy to, Lori. So this is really the crux of it, I think. And I think this is a challenging issue for 2 reasons. One, there's really sort of no guidelines currently in place to what your blood pressure goal should be after you deliver a baby. That's the reality, meaning the AHA and the ACC in my land in the cardiology world, we have definitions for what high blood pressure is. ACOG has definitions during pregnancy, but then this postpartum right after delivery becomes this no man's land where it's like, do we push them less than 120/80? People are like, wait, they just delivered a baby. 160/110 sounds a little crazy, particularly to cardiologists like myself. So this is a great point because when we at least look at our hospital level data, a lot of the women who are quote unquote bounce backs or those first 1 week hospital readmissions, when we go back and look at their charts, most of them had mildly elevated blood pressures. So it's absolutely right that some of the work that I think we're doing and some of the recommendations that I think we'll make, and some of this is, you know, we may not have all the evidence to back it, but there's a lot of experts that are going to help us and guide us with best practices is, well, is there something we should be doing before the woman leaves the hospital to make sure that we're also reducing mortality, morbidity, and also hospital readmission? So this is an excellent point. I think we all struggle with this. I think that this is an important part of the initiative to just make sure that it's a part of it, right? That we at least give some guidelines as to who should be medicated or given meds before they actually leave the hospital. And hopefully they're being bridged to that 3-day BP check, which is also important. So maybe they don't meet criteria right when they leave the hospital, but potentially at 3 days, knowing that blood pressures rise from 3 to 6 days after delivery, there may be some women who look fine when they leave the hospital, but then in that 3 to 5 days, really where we see blood pressures naturally rise after women are discharged. So I love that you have brought up that point. And it's already on our radar, something that we're hoping to address with this initiative. Dr. Greaves, I don't know if you have anything else to add to that. We may have lost Cole.
Well, thank you, Dr. Cruciat. We have another question in the chat. Maybe Cole can hop in later. From Lindsay Greenfield, it's, can you provide more information for the data piece related to maternal morbidity and what specific criteria we include for the 5 additional cases we submit?
So I think that's a question for Dr. Rubio, and she may have dropped off with Dr. Greaves. However, what I can tell you is that we will do an in-depth data webinar. So there will be a special separate hour that we walk through all of these data questions with you so that we can answer them and make sure that we answer them correctly. So stay tuned for that is what I would say. We will do our best to make it crystal clear for you and as easy as possible to implement. That would be our goal.
Thank you, Lori. Colleen Rodriguez asks, is the prenatal daily aspirin for high and moderate risk women going to be part of this initiative?
Well, I mean, I'm not a clinical person, but I can answer this one. That the assessment of risk for that is supposed to happen at between 12 and 16 weeks. So it precedes our initiative by many, many weeks. Certainly, we hope that people who have risks are assessed appropriately and put onto low-dose aspirin. And there is a national campaign called Low Dose Big Benefits that the March of Dimes is implementing, and they are marketing it in Florida this year, trying to get attention from women. So we know that's going on, but it is not specifically a component of this bundle.
Lori, the other thing that I would mention is we struggled a lot with this. And one of the things that we think we could do, since we're focusing on education, is if a woman, whether they were on aspirin or not during the current pregnancy, have now been diagnosed with a hypertensive disorder pregnancy, those women should know that a future pregnancy would be one where they would definitely be candidates and should consider being placed on aspirin. So I think window is everything and timing is a lot. So even if it's this pregnancy, they weren't on it, they didn't have risk factors, they got preeclampsia, at least you're sort of counseling, and we need to make sure we educate women that's something that they can either expect, be a candidate, or look forward to if they do choose to have a future pregnancy. So that'll definitely be a piece of it.
Thank you. Are there any other questions? I have one more piece of information to share as we close, but I want to make sure we've addressed any other questions first. Has anyone else got a question? Do we have any hands up? All right. Well, I just want to share with you that one of the components of this initiative that's different than anything we have done in the past is that we have been able to purchase 5,000 blood pressure cuffs. They are validated wrist cuffs, and they will be available for hospitals that are enrolled in this initiative. And our hope is that you will have access to those cuffs to close some gaps. So in that postpartum measure, where we want you to make sure that they're scheduled for that visit, 3 to 7 days, where they have instructions on how to measure and report their blood pressure, that if need be, they also go home with a cuff in hand so that they can do that blood pressure measurement more easily, more conveniently, more consistently, so that they can detect any alarming numbers and report them to their providers before they get too high. So there will be information on that coming up. I think you'll see in the application, there's one little bullet that mentions that cuffs will be available. We don't know yet how many there will be available per hospital. That will depend on a lot of factors, such as whether you already have cuffs from another source. There are other entities in the state that are providing free cuffs right now. So if you've got enough from another source, we would ask that you not request some of ours. We want to make sure we get them spread out so as many women as possible get a cuff. So just wanted to add that in. More to come on that later. Any other closing thoughts? We're almost at the top of the hour. No more questions in the chat. Okay, well, you all know where and how to reach us. I want to thank our leadership team for their efforts today. This little hour is the culmination of months of work. And we are grateful for everyone's time and passion and energy on this. And we're really looking forward to working with you all in Prompt. Thank you so much.